So this is the presentation on disruptive impulse control and conduct disorders section of the DSM-5. The disorders that we're going to talk about within this category are oppositional defiant disorder, intermittent explosive disorder, conduct disorder. Antisocial personality is included in this section as well as the personality disorders section, so we're not going to go over that again because we just went over that last week. And then in class, we're going to talk about pyromania and kleptomania. So the chapter on disruptive impulse control and conduct disorders is new to the DSM-5. It brings together disorders that were previously included in DSM-4 in the chapter Disorders Usually First Diagnosed in Infancy, Childhood, or Adolescence, and also in the chapter Impulse Control Disorders Not Otherwise Specified. These disorders are all characterized by problems in emotional and behavioral self-control. Because of its close association with conduct disorder, antisocial personality disorder has dual listing in this chapter and in the chapter on personality disorders. Of note, ADHD is frequently comorbid with the disorders in this chapter, but is listed with the neurodevelopmental disorders in the DSM-5. So all children are oppositional from time to time, particularly when tired, hungry, stressed, or upset. They may argue, talk back, disobey, and defy their parents, teachers, and other adults. Oppositional behavior is often a normal part of development for 2 to 3-year-olds and in early adolescence. However, openly uncooperative and hostile behavior becomes a serious concern when it is so frequent and consistent that it stands out when compared with other children of the same age and developmental level, and when it affects a child's social, family, and academic life. In children with ODD, there is an ongoing pattern of uncooperative, defiant, and hostile behavior towards authority figures that seriously interferes with the individual's day-to-day functioning. So here are the DSM-5 diagnostic criteria for ODD. So a pattern of angry and irritable mood, argumentative and defiant behavior, or vindictiveness lasting at least 6 months, there's your duration, is evidenced by at least 4 symptoms from any of the following categories and exhibited during interaction with at least one individual who is not a sibling. So angry and irritable mood, this is a child that often loses his or her temper, that is very touchy or easily annoyed, and that is often angry and resentful. And remember, by often, it has to last at least 6 months. And then argumentative and defiant behavior, so this is a child that often argues with authority figures, so teachers, police officers, anybody that's in authority. For children or adolescents, and with adults. I'm not sure why that says that. Often actively defies or refuses to comply with requests from authority figures or with rules, often deliberately annoys others, and often blames others for his or her mistakes or misbehavior. And then the third criteria is this vindictiveness. So this individual has been spiteful or vindictive at least twice within the past 6 months. And remember, this is in comparison with other children of the same age and developmental level, and it also needs to affect the child's social, family, and academic life. Some of this is normal behavior, right, when adolescents or little kids lose their temper and are easily annoyed and they argue with their parents, but this is outside of the scope of normality. So the persistence and frequency of these behaviors should be used to distinguish a behavior that is within normal limits from a behavior that is symptomatic, which we just said. So in kids that are younger than 5, these behaviors need to occur most days for at least 6 months. In kids that are 5 and older, they need to occur at least 1 time per week for at least 6 months. And then other factors to consider is the child's developmental level, their gender, and their culture. And then the disturbance in behavior is associated with distress in the individual or others in their immediate social context. And like all the other disorders that we've talked about, negatively impacts social, educational, occupational, other areas of functioning. And here's your rule out. They do not occur exclusively during the course of a psychotic episode, substance use, depressive, or bipolar disorder. And the criteria are also not met for a disruptive mood dysregulation disorder, which we'll talk about, or which we did talk about when we talked about major depressive disorder. So make sure before diagnosing a child with anything, but really before diagnosing a child with ODD, that you rule out all of those other things because it can look like other things. The DSM-5 does indicate some specifiers when you make this diagnosis. So the mild specifier means that this occurred in one setting. So the child is oppositional at home or oppositional at school. Moderate is at least in 2 settings, and severe is kind of across settings, 3 or more settings. So the epidemiology of ODD, the prevalence rate is 1 to 11%. The average is around 3.3%. It varies depending on age and gender. It's more prevalent in males, but only slightly more prevalent in males, 1.4 to 1 in females prior to adolescence. The first symptoms appear during preschool years, and they rarely appear any later than adolescence. Oppositional defiant disorder often precedes the development of conduct disorder, and we're going to talk about this, but if you kind of envision a flow chart, it would go from oppositional defiant disorder to conduct disorder to antisocial personality disorder. So giving a child a diagnosis of this is giving a child a diagnosis of anything, in my opinion, but especially this one is kind of a big deal and something to be very careful about. Individuals with ODD have a high risk for developing anxiety disorders and major depressive disorders, and the diagnosis may lead to problems with adjustment as adults. So, as we just said, it might lead to antisocial behavior, impulse control problems, substance abuse, anxiety, and depression. We're going to talk a little bit more about comorbidity in a second, but ODD is comorbid with ADHD in adults and adolescents, substance use disorders, and anxiety disorders. It's important to remember that ODD looks like other things, especially in kids and in adolescents. So it looks like anxiety, it looks like depression. So you just have to be really careful when you're diagnosing it. In terms of causes, there is no clear-cut cause of ODD. However, just like the other disorders that we've talked about thus far, most experts believe that a combination of biological, psychological, and social risk factors play a role in the development of the disorder. Some biological factors include a parent with a history of ADHD, ODD, or conduct disorder, a parent with a mood disorder, such as depression or bipolar, a parent who has a problem with drinking or substance abuse, some impairment in the part of the brain responsible for reasoning, judgment, and impulse control, so that frontal lobe executive functioning part, a mother who smoked during pregnancy, exposure to toxins, and poor nutrition kind of up your risk factors for developing ODD. Some psychological factors include a poor relationship with one or more parent, a neglectful or absent parent, or a difficulty or inability to form social relationships or process social cues. So there's definitely an attachment piece to oppositional defiant disorder. Some social factors include poverty, being raised in a chaotic environment, abuse and neglect, lack of supervision, uninvolved parents, inconsistent discipline, and family instability. In speaking about comorbidity, research indicates that some children develop the behavioral symptoms of ODD as a way to manage anxiety or uncertainty. Anxiety disorders and mood disorders are similar to ODD in that they are often a response to uncertainty in an unstable home and school environment. These similarities make it more likely that ODD and anxiety disorder and a mood disorder such as depression will occur together. And remember, they look the same, so you really need to tease that out as a clinician. Among all conditions that coexist with ODD, ADHD is the most common. Both disorders share common symptoms of disruptive behaviors. However, children and adolescents who have both ODD and ADHD tend to be more aggressive, have more of the negative behavioral symptoms of ODD, and perform less well in school than those who have ODD alone. These children also tend to have more disruption in their families with their relationships with authority figures than children who do not have ODD. Doctors have found that ODD can be a precursor to conduct disorder, which we spoke about, and we're going to talk about conduct disorder in a couple minutes. A child or adolescent who has ADHD as a coexisting condition also seems to be at an increased risk of developing ODD. In addition, studies have shown that having ODD puts children and adolescents at risk of developing a mood disorder or antisocial personality disorder later in life, which we've talked about. While having ODD in a coexisting condition puts a child at risk for developing other more serious mental health issues, treatments exist that can improve the symptoms of ADHD, anxiety disorders, mood disorders, and learning and language disorders. Also, treating other mental health and learning conditions that occur along with ODD has been shown to decrease the behavioral symptoms of ODD. So if a child comes in and they have a comorbid diagnosis of ODD and anxiety, it's okay to treat their anxiety because that's going to lower their symptoms for ODD. Same thing with depression. If you're going to treat their depression, then that might lower their symptoms for oppositional defiant disorder. We're going to talk a lot about ODD in class this week. So the next one we're going to talk about is intermittent explosive disorder. So in 2006, a little-known mental disorder marked by episodes of unwarranted anger, they found that the National Institute of Health found that it's more common than they previously thought. So they funded a study, and what they found in the study is, depending upon how broadly it's defined, intermittent explosive disorder affects as many as 7.3% of adults, which is 11.5 to 16 million Americans in their lifetime. The study, based on data from the National Comorbidity Survey Replication, which we've seen studies based on that before, a nationally representative face-to-face household survey of 9,282 U.S. adults, was conducted in 2001 and 2003. So people with intermittent explosive disorder may attack others in their possessions, causing bodily injury and property damage. Typically beginning in the early teens, the disorder often proceeds and may predispose for later depression, anxiety, and substance abuse disorders. Nearly 82% of those with IED also had one of these other disorders, yet only 28.8% ever received treatment for their anger. That was reported by Ronald Kessler, PhD, from Harvard Medical School and their colleagues in 2006 in the Archives of General Psychiatry. And this suggests that treating anger early might prevent some of these co-occurring disorders from developing. So that's what you guys can do when you work with kids and adolescents. You can help treat anger. Evidence suggests that IED might predispose towards depression, anxiety, alcohol, and drug abuse disorders by increasing stressful life events such as financial difficulties and divorce. Given its earlier age of onset, identifying IED early, perhaps in school-based violence prevention programs, and providing early treatment might prevent some of the associated psychopathology, proposed those researchers. Although most studies, respondents with IED had seen a professional for emotional problems at some times in their life, only 11.7% had been treated for their anger in the 12 months prior to the study interview. Although the new prevalence estimates for IED are somewhat higher than previous studies have found, the researchers consider them still to be conservative. For example, anger outbursts in people with bipolar disorder, which often overlaps with IED, were excluded. Previous studies have found little overlap between IED and other mental illnesses associated with impulsive violence, such as antisocial and borderline personality disorders. So here's the DSM-5 diagnostic criteria for IED. Recurrent behavioral outbursts representing a failure to control aggressive impulses is manifest by either of the following. So you need either one or either number two. So verbal aggression or physical aggression towards property, animals, or other individuals. Here's your duration, occurring twice a week on average for a period of 3 months. The physical aggression does not result in damage or destruction of property and does not result in physical injury to animals or other individuals. Or number two, 3 behavioral outbursts involving damage or destruction of property and or physical assault involving physical injury against animals or other individuals occurring within a 12-month period. The magnitude of the aggressiveness expressed during the recurrent outburst is grossly out of proportion to the provocation of any precipitating psychosocial stressors. So this is abnormal behavior. This is not I'm angry and it's normal, and this is abnormal behavior. The recurrent aggressive outbursts are not premeditated. They are impulsive and anger-based and are not committed to achieve some tangible object such as money or power. And the aggressive outbursts cause either marked distress in the individual or impairment in their occupational interpersonal functioning, or are associated with financial or legal consequences. The individual has to be at least 6 years old to be diagnosed with IED, and the outbursts are not better explained by another mental disorder. And then there's a note: for children 6 to 18 years, aggressive behavior that occurs as part of an adjustment disorder should not be considered for this diagnosis. So if you've got a child or an adolescent with with an adjustment disorder with mixed conduct, that would not be, you would not diagnose them with IED. You would diagnose them with adjustment disorder with mixed conduct. Let's see. So this note was in the DSM-5 as well. The diagnosis can be made in addition to ADHD, conduct disorder, ODD, or autism spectrum disorder when recurrent impulsive aggressive outbursts are in excess of those usually seen in these disorders and warrant independent clinical attention. So this is something that you would diagnose along with something else and treat. You would treat them for their anger. So some epidemiology of IED: 2.7% is the prevalence rate in the U.S. as of the time that DSM-5 came out. It's more prevalent among individuals that are younger, from like 35 to 40, than older individuals plus 50. It's more prevalent in individuals with a high school education or less, which I think is pretty interesting. Onset is most common in late childhood or adolescence, and it rarely begins after age 40. The course may be episodic with recurrent periods of impulsive aggressive outbursts. Trauma during the first 2 decades of life increase the risk of developing IED. First-degree relatives that have IED or ODD or conduct disorder increase the risk of developing that. And then some twin studies have indicated a substantial genetic influence. And then brain research has also indicated causal factors for IED. And we will talk more about that in class. So the last one we're going to talk about is conduct disorder. Occurring in children and teens, conduct disorder is a persistent pattern of disruptive and violent behaviors that violate the basic rights of others or age-appropriate social norms or rules and causes significant impairment in the child's or family's daily life. An estimated 8.5% of children and youth meet criteria for conduct disorder at some point in their life. Prevalence increases from childhood to adolescence and is more common among males than females. Here is the DSM-5 diagnostic criteria for conduct disorder. So, a repetitive and persistent pattern of behavior in which the basic rights of others or major age-appropriate societal norms or rules are violated is manifest by the presence of at least 3 of the following 15 criteria in the past 12 months. So 3 criteria in the past years from any category below, but one of them has to be present within the last 6 months. So aggression to people or animals, often bullies, threatens, or intimidates others. And remember, this is outside the realm of normal too. So developmental level, age, all that stuff, culture, all that stuff needs to be taken into consideration because, and we'll talk about this, but a diagnosis of conduct disorder has some major implications for when you are older, one of them being a diagnosis of antisocial personality disorder, but other implications that we'll talk about this week. Often initiates physical fights, has used a weapon that can cause serious physical harm to others, has been physically cruel to people, has been physically cruel to animals, has stolen while confronting a victim, has forced someone into sexual activity, or destruction of property, and or has deliberately engaged in fire setting, so pyromania, which we'll talk about this week, with the intention of causing serious damage, has deliberately destroyed others' property. I had one kid once in school that was a fire starter, and he was a scary kid, so we can talk about him too. Deceitfulness or theft, so has broken into someone else's house, building, or car, often lies to obtain goods or favors or to avoid obligations, and has stolen items of non-trivial value without confronting a victim. And then serious violations of rules, so stays out at night despite parental prohibition, beginning at 13 years old, has run away from home overnight at least twice while living in the parent or parent surrogate home, or once without returning from a lengthy period, and is often truant from school beginning before the age of 13. So you can see how the trajectory from conduct disorder could lead to antisocial personality disorder. It reminds me of kind of the pipeline to prison, right? It reminds me of criminal behavior. So the disturbance in behavior causes clinically significant impairment in school, academic, or occupational functioning, and if the individual is 18 years or older, the criteria has not been met for antisocial personality disorder. So you can still be diagnosed with conduct disorder if you are over the age of 18, but only because the criteria haven't been met for antisocial personality disorder. So there are some specifiers, and we are going to go way into these in class, so I just listed them. Oops, sorry, my phone's ringing. So I just listed them on here for you. So child onset type, one symptom is there before age 10. Adolescent onset type, no symptoms are there prior to age 10, and then unspecified onset is when you don't have enough information to determine when the symptoms started. And then these we're going to go over in class. So with limited prosocial emotions, lack of remorse or guilt, callous and lack of empathy, unconcerned about performance, or shallow or deficient affect. And then your other specifiers would be mild, moderate, or severe. So mild would be there's a few problems, and minor harm has been done to somebody. Moderate or severe would be many problems and considerable harm. And the DSM-5 was very clear in defining moderate, saying it was in between mild and severe. So use your clinical judgment on that one. And then the epidemiology of conduct disorders. So 2% to plus 10% in the 1-year population is the prevalence. It's consistent across various countries that differ in race and ethnicity, so the prevalence is consistent. Rates rise from childhood to adolescence. It's more prevalent among males than females. It can occur during preschool years, but the first serious symptoms usually emerge in middle childhood. ODD is a common precursor to conduct disorder, which we talked about. Onset is rare after 16 years of age, because then it would look like it would be more likely to be antisocial personality disorder. Many individuals with conduct disorder with few or mild symptoms achieve adequate social and occupational adjustment as adults. So there's this whole table of prognosis predictors that we're going to look at in class on Friday that talk about, age of onset and symptoms and what the prognosis looks like for treatment based on all of these different factors. Early onset predicts a poorer diagnosis. These individuals are at risk for mood disorders, anxiety disorders, PTSD, impulse control disorders, psychotic disorders, for everything. Individuals with conduct disorder, there's a high comorbidity rate. It may lead to antisocial PD, and then there's a comorbidity rate. So conduct disorder, next slide. Here are some risk factors, and we're going to go into these more in class 2, but conduct disorder may be preceded by temperamental risk factors such as behavioral difficulties in infancy and below average intelligence. Similar to ODD, environmental risk factors may include harsh or inconsistent child rearing practices and or child maltreatment, parental criminality, frequent changes of caregivers, large family size, family psychopathology, and early institutional living may also contribute to risks for developing the disorder. Community-level risk factors may include neighborhood exposure to violence, peer rejection, and association with a delinquent peer group. Children with a parent or sibling with conduct disorder and other behavioral health disorders like ADHD, schizophrenia, severe alcohol use disorder are more likely to develop the condition. And children with conduct disorder often present with other disorders as well, like we've talked about, including ADHD, learning disorders, and depression. There are some really interesting studies around conduct disorder and risk factors. One of them found that individuals with conduct disorder have a slower resting heart rate, which is different from any other diagnosis in the DSM-5. And then the brain structure as well, which we'll go into in class. We're also going to talk about in class temperament and the different kind of temperaments that a child can have, and how temperament leads to personality. And we'll do some case studies, and you guys will totally be experts in the disruptive behavior disorders.